Hello everyone. Today our topic is evaluation process and treatment planning. Introduction. Following the physical examination, patients expect some answers regarding their condition and return to normal activity and function. Explanation and planning are considered to be the main reason behind the patients visiting to see a healthcare clinician. They want to understand what is causing their aches and pains. The aim of this step in the healthcare consultation is to empower patients with knowledge regarding the nature of their condition, different treatment options, prognosis, and alternative options in the case of unsatisfactory outcome. There are three options for the content of explanation and planning in the Calgary-Cambridge model. The focus could be on the pathology itself, discussing the significance of the problem. The conversation can revolve around the negotiation of a plan of action which is mutually acceptable to both the patient, family unit, and healthcare practitioner. Possible further investigations and/or procedures can be center of the discussion. Principles. First, diagnostic summary. Your provider will review your substance use patterns, medical history, and mental health conditions. Based on these assessments, they will summarize the main problems they brought you to the treatment and recommendations like medication and behavioral therapy. Problem list. This list outlines specific issues that you want to target during treatment and a summary of the signs and symptoms that illustrate the problem. Goals. After you come up with your problem list, it's time to think about solutions. Goals are brief statements about what you want to change and should be. A. Based on your problem list, at least one should directly relate to the substance abuse. B. Broad. Instead of focusing on eliminating a behavior, focus on how to replace a harmful behavior with a healthy one. C. Reasonably achievable during the treatment period. Objectives. Goals are things you want to change, while objectives are concrete steps you will take to achieve each of those goals. Objectives should be SMART. S-M-A-R-T. S for specific. M for measurable. Actions that can be observed. A for attainable. Reasonable to achieve within the treatment time. R for relevant, related to the issues on your problem list. T for time limited, have a target date for completion. Interventions. These are the methods your treatment specialist will use to help you complete each your objectives. Tracking and evaluating progress. Your provider will keep comprehensive notes in your chart to track your progress and evaluate whether the treatment is working. This typically includes details about your response to treatment, changes in your condition, and adjustments to the plan. They may also ask you to write down your thoughts, your feelings, and behaviors. Planning long-term care. During treatment planning, your clinician may discuss long-term maintenance care and relapse prevention. After you have completed the initial treatment program, your continuing care plan may include attending regular 12-step meetings or support groups, continuing therapy sessions with a counselor, neurological assessment. BOBAT neurodevelopmental treatment approach. First, reintegration of function of the two sides of the body. Second point, proximal to distal positioning is recommended. Third point, weight bearing is provided on the affected side to normalize tone. Fourth point, tasks should begin from a symmetric midline position with equal weight bearing on the affected and unaffected sides. Fifth point, movement toward the affected side is encouraged. Principles of positioning. Special resting hand splints may be ordered to prevent contractures. Remove periodically to assess the skin for pressure ulcers. Reduce edema by elevating the hand higher than the elbow or by using elastic gloves. Positioning. Importance of positioning. Point number 1. Prevent development of musculoskeletal deformities. Point number 2. Contractures. Point number 3. Ankylosis, stiffness and rigidity of joints. Point number 4. Pressure ulcers. Point number 5. Decreased vascular supply. Point number 6. Thrombosis. Point number 7. Edema. Sitting. The conscious patient may sit on the side of the bed using the over bed table and pillows for the support. For the weak, debilitated patient who cannot hold up the neck or their head, a high back chair that extends to the top of the head is most effective. It is the most effective. Mobility, transfer, and ambulation. Transfer. Types of transfer. First, 2 persons lift. Physical transfer by at least 2 staff members. No active patient participation. Second, mechanical lift. Transfer using a lifting device that is operated by staff members. No active patient participation. Principles of transfer. Transfer toward the unaffected side. Patients should wear properly fitted flat shoes. Never tug on the paralytic arm by pulling on the upper arm or shoulder. If balance is unsteady, stand on the affected side, ready to grasp the belt around the patient's wrist. Range of motion exercises. Types. First, passive exercises. Second, active exercises. Third, active assistive exercises. Fourth, resisted exercises. Resisted exercises are further divided into two. A. Manual resisted exercises. B. Mechanical resisted exercises. Fifth, isometric or muscle strengthening exercises. Manual resisted exercises. Tilt table for orthostatic hypotension. Mirror feedback therapy with parallel bars. Patient is told to walk on the parallel bars, watching himself in the mirror, which gives biofeedback. Mat exercises. Treatment of pain and inflammation. First, heat therapy. Second, mechanism of action. Third, increases blood flow and the extensibility of connective tissue. Fourth, decreases joint stiffness, pain, and muscle spasm. Fifth, reduces inflammation, edema, and exudates resolve. Transcutaneous electrical nerve stimulation, also known as TENS. Use of electric current to stimulate the nerves. Uses: A. Chronic lower back pain. Second, neuralgia. Third, contusion. Biofeedback. Electromyogram, also known as EMG. Second, galvanic skin response. Speech therapy. Auditory training, lip reading, sign board. Bladder dysfunction and retraining. Bladder control is an integrated function of the brainstem, spinal, and cerebral level. Alterations in urinary elimination patterns can be classified generally into urinary incontinence UI and urinary retention. Bladder training. Bladder training, also called bladder retraining, includes several variations. Three primary components of education: scheduled, voiding, and positive reinforcement. The patient needs to be educated to understand the physiology, pathophysiology, technique, and the desired outcome. Stroke. Stroke is when poor blood flow to the brain results in cell and tissue death. There are two main types of stroke. First, ischemic, due to lack of blood flow, and second, hemorrhagic, due to bleeding, due to loss of blood. They result in part of the brain not functioning properly. Rehabilitation protocol for stroke. First, positioning. Second, mobilization and stretching. Third, weight bearing activities. Fourth, chest PT or chest physiotherapy. Fifth, pain relief. Sixth, speech therapy. Seventh, bowel and bladder care. Spinal cord injury. A spinal cord injury or SCI is damage to the spinal cord that causes changes in its function, either temporary or permanent. These changes translate into loss of muscle function, sensation, or autonomic function in the parts of body served by the spinal cord below the level of lesion. Rehabilitation of spinal cord injury. Safe transportation, traction, positioning, active and passive range of motion, mat work, orthosis, spinal corsets, crutches, gait training, mobility training. Parkinsonism. Parkinsonism is a clinical syndrome characterized by tremor, bradykinesia, rigidity, and postural instability. Rehabilitation protocol of Parkinsonism. First, reduction of rigidity and maintaining flexibility. Second, balance training. Third, coordination exercises. Fourth, breathing and chest expansion exercises. Fifth, improvement in psychological well-being. Orthopedic assessment. One of the common assessment recording methods used in the problem-oriented medical records method, which uses SOAP notes. SOAP stands for the 4 parts of the assessment. S for subjective, history. O for objective, observation and examinations. A for assessment, interpretation. Continuous assessment is needed to determine how patient's condition is responding to the treatment. In general, the therapist compares one side of the body, abnormal or injured, with the other side of the body, which is in good condition or which is normal. Principles and concepts. A correct diagnosis depends on knowledge of functional anatomy, an accurate patient history, diligent observation, and a thorough examination. The differential diagnosis process can involve the use of clinical signs and symptoms, physical examination, knowledge of pathology and mechanism of injury, provocative tests, and laboratory and diagnostic imaging techniques. The purpose of the assessment should be to fully understand the patient's problem. Examination of a patient with an orthopedic problem. First, questioning. Second, inspection. Third, palpitation. Fourth, auscultation and percussion. Fifth, assessment of the function. Sixth, special tests and measuring. Seventh, additional methods. Observation. Inspection. What is the body alignment? Is there any obvious deformity? Are the soft tissues contours normal? Any muscle wasting? Is the color of the skin normal? Is there any swelling or redness? Is there any abnormal sound in the joint and movement? What is the patient's facial expressions? Examination of movements. Active movements, physiological movements, passive movements, end feel. A hard or bony end feel, a firm or springy end feel, a soft end feel. Resisted isometric movements. Strong and pain-free. No lesion in the contractile unit. Strong and painful. Mild or moderate muscle strain. Weak and painful. Severe lesion around the joint. Weak and pain-free. Rupture of muscle, tendon or injury of nerve supply. Functional movements, activities of daily living, ADL. Eating, dressing, transfer, walking, shopping, activities. Special tests. Specially designed tests to confirm preliminary diagnosis or to make differential diagnosis. For example, Latchman test to check on torn anterior cruciate ligament injury or ACL. Reflexes, cutaneous distribution. The therapist test deep tendon reflexes using reflex hammer and skin sensation using pin prick to obtain an indication of the nerve or nerve root supplying the reflex or the dermatome. Palpitation. Determine joint tenderness, feel variation in temperature, discriminate differences in tissue, tension and muscle tone, note any abnormal sensations or crepitus. Diagnostic imaging, X-ray, CT scan and MRI. Problem list according to the priority. Treatment plan. Short-term goals: decrease pain, decrease inflammation, decrease effusion, increase range of motion. Long-term goals: increase muscular strength, endurance, flexibility, increase balance and proprioception. Methods. Refer back to the physician if new problems arises or if patient is not responding to physical treatment. Critical question. After few sessions of physical therapy, one of your patient is not responding enough to treatment. What do you think? Osteoarthritis. It is believed to be caused by trauma, either overt or as an accumulation of microtrauma over years. Although there is also a hereditary form called primary osteoarthritis that occurs primarily in middle-aged women. Most commonly affected areas: knees, hands and hip joint. Joint space narrowing, sclerosis, osteophytosis, subchondral cyst or quadriceps sets, standing terminal extension, seated leg presses, partial squats, not deep, step-ups, flexibility in arm exercises, calf, hamstring and quadricep stretching, knee flexion, toe extension, stationary biking, unloading braces. Fibromyalgia. Fibromyalgia is a syndrome characterized by widespread chronic unabated pain in addition to a host of several additional comorbidities that can severely impact and disrupt a person's daily life. The symptoms associated with fibromyalgia may originate from abnormal central nervous system output. Fibromyalgia isn't just one condition, it's a complex syndrome involving many different factors. Fibromyalgia is characterized by sensitization of the central nervous system, which explains the wide variation in symptoms. Fibromyalgia is more prevalent among women, and the vast majority of those with fibromyalgia are women. It includes morning stiffness, tingling or numbness in hands and feet, headaches, migraines, constipation and diarrhea, thinking and memory abnormalities, fibrofog, painful menstrual periods, fatigue, trouble sleeping, jaw pain, abnormal muscle pain and malaise after exercises, dizziness or light headache, skin and chemical sensitivities, deep aching, throbbing, shooting, radiating, stabbing pain, non-cardiac chest pain, heart palpitations, shortness of air, profuse sweating, feeling of swollen extremities, sensitivities to all the senses, loud noises, bright lights, some foods, odors, etc. Feeling of depression and anxiety. According to the most recent interview assessing the benefits of exercises in the management of fibromyalgia, there is gold level evidence that supervised aerobic exercise training has beneficial effects on physical activity or capacity and FM symptoms. Strength training may also have benefits on some fibromyalgia symptoms. Further studies on muscle strengthening and flexibility are needed. Research on the long-term benefit of exercise of fibromyalgia is needed. Light aerobic exercises in most days of week is highly recommended for those with fibromyalgia. In a systematic review published in the Journal of Rheumatology, it was concluded that aerobic exercise training only offers those with fibromyalgia significant beneficial effects on physical function, well-being, and potentially pain. Strength training and flexibility, however, have yet to be studied in depth. Another study found that the structured physiotherapy alone, not including aerobic exercises as well as amitriptyline medications alone, significantly decreases disability of those with fibromyalgia, as measured by the Fibromyalgia Impact Questionnaire (FIQ). Physiotherapy consisted of the following: relaxation techniques, stretching, strengthening. Manual lymph drainage therapy and connective tissue massage have also been studied in women with fibromyalgia. Researchers used the Fibromyalgia Impact Question and the Nottingham Health Profile to measure the impact of the treatment. Their research suggests that both manual lymph drainage therapy and connective tissue massage show improvements in both the FIQ and the Nottingham Health Profile. However, there were significantly greater improvements in the group that received manual lymph drainage therapy, suggesting that manual lymphatic drainage therapy may be preferred over connective tissue massage. Thank you.